I'm going to demonstrate the passive examination of the knee. First of all, flexion. When we're doing the passive movements for the knee, as with all examination passive movements, we need to keep an eye on the patient's face for any signs of pain and discomfort. And the patient is warned to indicate if there's any pain. We stop the examination, then we assess the degree of pain and the location of the pain. Often when they tell me there's pain, I want to know exactly where it is, and to avoid any misconceptions, I ask them to point with one finger and perhaps tell me on a scale of 0 to 10 about the intensity of the pain. Okay, we take first of all into flexion. As with all passive movement tests, there are 3 gentle overpressures at the end. And here, if we're using a Maitland approach to clinical reasoning, we can also add in flexion adduction and flexion abduction. We internally rotate the tibia when we're going into flexion abduction, and somewhat externally rotate when we're going into flexion adduction. The trick to remember here is that the heel goes first. Then, while the knee is flexed, we can look at internal and external rotation. For knee internal and external rotation, take the hip up into flexion. You're facing away from the patient with your body, but you're looking at the patient for signs of pain. You use both hands going in opposite directions for the movements. So the fingers are on the lateral aspect of the heel and the medial aspect of the foot for external rotation. And you move it like this. The movements can be fairly vigorous movements. And for internal rotation, the opposite. And these movements can test for meniscal tears, external rotation for the medial meniscus, internal rotation for the lateral meniscus. This test, done in prone with some grinding, can also do the same thing. For McMurray's test for the menisci, we take the knee into flexion, and for the medial meniscus, we'll apply a varus force to the inside of the knee. We'll have the tibia in external rotation and then take the knee from flexion to extension. It's kind of a semicircular movement here, and I'm grinding the medial meniscus here. This varus force really kind of closes down the medial joint compartment. For the lateral meniscus, the upper leg steps backwards a little bit. We apply a valgus force to the knee and internally rotate the tibia. And this is a semicircular movement on the other side of the circle, so to speak. And this movement is grinding away at the lateral meniscus, closing down the lateral compartment of the knee. A positive sign is pain plus a click. When we're looking at cruciate ligaments, we can start off with the draw tests. There's the anterior and posterior draw. I like to just sit on the edge of the bed and just put the outside of my thigh on the toes or the distal foot of the patient. Make sure the hamstrings are relaxed, especially when the people are in pain. They tend to tense their hamstrings up. Just tell the patient to relax and place your hands in the posterior, your fingers at the posterior aspect of the knee. The joint line is just here, and my thumbs are on the anterior aspect of the joint line. Be careful to have a broad touch on the upper calf at the posterior aspect of the leg. Make sure it's not too pokey. Gently pull on the upper tibia to translate the upper tibia forwards. And you can feel the movement of the tibial plateau as it translates anteriorly here. What we're looking for is excessive translation. And of course, having two legs, we can always compare to the other side. If we're doing the posterior jaw test, again with the heel of the hand, it's quite a bony area, the anterior aspect of the tibia. Be careful not to cause discomfort to the patient, but with a broad contact that can be achieved. And again, you just press forwards on the tibia, feeling with your thumbs as the tibial plateau moves posteriorly, just assessing the degree of movement there. For Lockman's test, you've got about 20 to 30 degrees of extension, hand around the tibia, other hand around the lower femur, and you're just applying an antero-posterior, posterior-anterior movement, looking and feeling for the translation of the tibia on the femur. If you have a large patient with big legs or you have small hands, you can place a pillow under the thigh, like so, and that can possibly help you. You can have a colleague stabilize here, or possibly you can place your thigh underneath the leg and try and do it like that. The pivot shift test is another test for, and it's a very specific test for anterior cruciate rupture. The patient is in knee extension. The tibia is internally rotated and a valgus force is applied to the knee. From this position, you flex the knee and then extend it. The action of the iliotibial band in flexion is a knee extensor, but in knee flexion, it becomes a knee flexor. So when there's an anterior cruciate ligament deficient knee, there will be a relocation of the joint as you flex the knee, because the cruciate ligament is responsible for the rotary stability of the knee. So there's going to be a big clunk there. It's unmistakable. Once you've felt it, you'll always know it. For assessing the medial collateral ligament of the knee, support the foreleg under your arm, slight flexion. The fingers can be placed on the medial joint line, or the index finger here, medial joint line. The outside hand is applying a valgus force here. You can feel the gapping on the inside of the knee joint, the medial aspect of the knee joint. It's very awkward when testing the lateral collateral ligament for that sort of position. So what we do here is, again, turn our back to the patient, looking at the patient. We support it here and press out like that. We're actually pressing in. It's supported on the inside. Again, pain is a positive test. For knee extension, cup your hand around the heel of the patient. Place the heel of your hand, fingers pointing down, over the tibial tubercle. Again, try and give it a broad sort of area of pressure rather than a sharp pressure point. Looking at the patient, taking into extension with 3 overpressures. Now, we can follow the Maitland clinical reasoning model, and we can also add in extension adduction by slightly externally rotating the knee in the same sort of pressure, or flexion abduction by slightly internally rotating the knee, the tibia, and the same sort of pressure there.